Hello and good evening. Guess what time it is? It's 4 o'clock in the mountains, which means 6 o'clock on the East Coast. And there is one place that you need to be right now, and that is right here. Fertility with Fink and Friends. I am Fink, and you are friends. And it is wonderful to be with you here this Tuesday evening, as we are every Tuesday at this time, where we can get together and talk about all those things that are important to us. It is our safe place. It is our happy place. It is the place where we can talk about what's important, and that is women's health, fertility, getting you pregnant, building your family, doing those things that we do to make you and yours whole. My name is Dr. Randy Fink, and I am the clinical director of IVF services here at CNY Fertility in Colorado. Great to be with you from Colorado Springs, and we've got a bunch of different feeds here as we do every Tuesday. We've got LinkedIn, Facebook, what else? YouTube right here in the middle. We've got two different Instagram feeds. We've got CNY over here. We've got my Instagram, Randy Fink MD, right here. And so let's see who has joined us. Jamie Marie Newton, thank you, or Newton. Thank you very much for being here this evening. You are number one on my list, Mrs. Villarreal, Jay Duro. Hello to Tracy Castillo. Thank you for being here. Hi, Janine Staley in Miami. Thanks for being here. Elisita, I believe that says. Maggie Cox, Kelsers, thanks for being here. As always, fit and healthy. Thanks, Jamie. I will more than likely be in my cycle during my consultation. Okay, and a special hello to Brandis Courtney. Brandis Montez is our wonderful nurse practitioner here, and she has some great content on her Instagram site, Brandis Courtney. I encourage you to take a look there as well. Let's see who we've got over here on the CNY Instagram. Rosa, you are number one, and a special hi to Angelina Foxy. Thanks for who is visiting in Ohio, as I understand, from her home base in Minnesota. Thank you for spending your vacation time with me here. Hi to Jenny. It looks like Danelle, Nisha Brookini, Mama Fauna, Sharika Nation. Hello from, is that Jamaica? Fabulous. Love the place. You may not know this, but I lived in Jamaica for a while back. Seemed a long time ago, but some of my very, very dear friends are in Mobay and love the place. Hi to Cutie Camp, the Cowgirls Bunkhouse. I like the name of that. I am Y Daniels. Good to see you, Anna B. Kissing her. I like it. Just got news. My transfer is next Friday. Well, that is fantastic. It is great to be excited about an upcoming transfer, and we will all keep our fingers crossed together here for you, Anna. Let's see. K Dreams Rosa asks, how much of Orilissa will be enough to suppress endometriosis before an FET? I have no pain and have been prescribed the 200 milligram dose. So for Orilissa, which is an oral medication that's used to suppress endometriosis before an embryo transfer, I typically do 200 milligrams twice daily. There's another dose, it's 150 milligrams that can be used once daily. I think 200 twice daily is the recommended dose, and so that's the one that I use there. Rosa and Maggie Cox over here on my Instagram says, how long should a laparoscopic surgery and 7 weeks of Orilissa suppression last? Should an FET be back to back, considering suppression for another month after a failed FET? Oh, I see. So you had laparoscopy and you did suppression, 7 weeks of Orilissa. How long should that suppression last you? We think that suppression probably lasts 6 to 9 months. There is conflicting data on that because there is no good data that looks at repeating either a second look laparoscopy or doing another test for endometriosis in another receptiva. But we believe 6 to 9 months, and hopefully that is plenty enough time there, Maggie, for you to get pregnant. Hi to all our friends over here on Facebook and YouTube, and and LinkedIn. So Liliana is here, says hello, thank you, Tracy Allen. We've got Giura and Michelle and Mandy. So let's see what we have. Tracy says, I just had a hysteroscopy with a polypectomy. I plan on doing an egg retrieval in October or November. Is there anything I should take to suppress endometriosis in the meantime? If so, should uh, I stop taking it with the upcoming retrieval? Okay, so you had a hysteroscopy with a polypectomy. I'm not sure there, Tracy, where the endometriosis is coming from. But so if you're known to have endometriosis, the recommended suppression is 60 days. 60 days of suppression before doing an embryo transfer. And then you also talk about doing a retrieval. So I would certainly recommend that you do the retrieval, get your eggs, make your embryos. Think about getting as many eggs and making as many embryos as you can right off the bat, because we want to get eggs from you as soon as we can, really as early as we can, because the earlier they come from you, the greater the probability that the DNA in those eggs will be stable, and you can make nice normal embryos from them. So first task, get eggs, make embryos. Put off anything about suppression or embryo transfer until you have banked enough embryos to feel comfortable that that's enough to get you pregnant. Hopefully that helps. Giara Barbara says, thank you for your lovely support. My pleasure. I got my 9th FET with the donor egg in Syracuse on the 17th of August. I am 53 years old. After transfer, I had a low progesterone result, 8.4 only. Yesterday, Dr. Kiltz doubled my PIO. Is it not too late? Any hope for me? Well, so the two questions that I would have there are, first, is it that you're not metabolizing your progesterone in oil correctly, or is the progesterone just not high enough because the pregnancy itself may not be healthy? So no, I would say, the reason that we do the midway labs is so that we can see what that progesterone level is. And if it's not high enough, then we increase it. So yes, I have seen on many an occasion that folks will have a low progesterone at midway, we increase it, and then that pregnancy ends up sticking, and you have a positive beta by the time you do your pregnancy test. So our fingers are crossed there, my friend, for sure. Michelle Stewart says hello from Tennessee and good afternoon, or actually in your case, good evening to Tennessee. How long after the first initial consultation can the whole transfer process happen? Well, so the way the logistics of the whole IVF thing work, you have a consultation. Usually we then connect you up with what we know of as our consultation navigators, and they will contact you, help walk you through the logistics, the day-to-day, getting the medications in hand, and helping you to set up your monitoring. Where are you going to do your monitoring during your cycle if you're doing that remotely? Once all that has been done, really, when we do the laboratory test, that first month I'll usually consider to be kind of a diagnostic month. And so in that diagnostic month, we want to get your whatever type of imaging needs to be done, and your blood tests. And if you're doing a genetic carrier screen, which I strongly do recommend, want to knock that stuff out. But really, once that's done, as soon as you get a period, we can start you on the process. And that's often a surprise to people, because in many cases they have waited many months to get that initial consultation. But once you are over the fence and you've had that consultation, the process can actually begin pretty quickly. So let's say that you do your stimulation. That process lasts for typically 9 to 12 days, after which you get a trigger shot. The trigger tells the ovaries, we are ready to come for those eggs. We have your retrieval 35 hours later. We get the eggs, we make the embryos. We have the partner sperm here, or the donor sperm, wherever it's coming from. We make the embryos. It typically takes either 3 days for a day 3 embryo, or 5, 6, or 7 days for a blastocyst. Then, if you're going to do a transfer, you can do a fresh transfer. In some cases, the fresh transfer, we will tell you, isn't the best idea. There may be a hormonal situation where doing a fresh transfer is not advised because maybe the environment is not going to be so hospitable to an embryo. The hormone levels might tell us so. But a fresh transfer, either day 3 or usually day 5, or you can freeze the embryos, come back the next month or any month that you like, because once those embryos are frozen, they're stopped in time and they just wait for you. Even the very next month, you come back and do an embryo transfer. If you're going to do PGT testing, which is pre-implantation genetic testing for aneuploidy, that tells us basically what the PGT is best used for is taking a large group of embryos and narrowing down. Oh, what happened? I think we just lost a camera connection. Let's see if we can. Video and no camera. There we go. Oh, hi. If Well, I have absolutely no idea what I was just talking about. No, we're talking about PGT testing. If you do the PGT, so best use of PGT is taking a big group of embryos and helping to narrow down that group that has the highest probability of being able to get you pregnant. Because in most cases, when folks do an embryo transfer and they don't get pregnant, the most common reason is a chromosomal one, that it's an embryo issue. And so we can take embryos and test them to see which are the ones that are normal, and those have the highest probability of getting you pregnant. So if you're going to do PGT, those embryos are biopsied when they are blastocysts. So that's typically day 5, sometimes day 6, and occasionally day 7. And it takes anywhere right now, it's taken about 10 to 14 days to get those results back. So that's kind of the timing that we're looking at, Michelle, and we'll wish you the very best of luck. Hi to Susanna. Hello to Zenaida in Miami. Oh, my Glinda, I'm watching from Vegas. Thank you so much for being here. Noodles for Life says, I'm 43 years old and I'm doing an FET this cycle. How many day 3s do you recommend to transfer? Let's see. So really, we will. So it depends on how many embryos you have there, Noodles. What we know is that at 43, a large portion of the eggs that we create are not going to be normal. And so we will create embryos that are not normal, and those embryos typically will not implant. And in that scenario, it means that you don't get a positive pregnancy test. So the advantage at 43 is that you are within the guidelines to transfer multiple embryos. And so multiple embryos means probably, I would say maybe think about 3 embryos of a day 3 embryo. You can transfer, I believe at 43, up to 4 to 5 embryos. To be honest with you, we've done it before, but start getting nervous. The realistic issue there is that they're not, we're lucky if we can get one to stick. And that's what we're hoping for, that one of those embryos will be normal and it will continue to grow. The odds that what we don't want is we really don't want you to have multiples. We don't want you, having twins. We certainly don't want you to have triplets or anything else. And so in other situations, we're very hesitant about multiple embryo transfers. But at 43, we know that they're not all going to be normal, so they won't all stick. And I would say 3 is probably a good number to consider their Noodles, not knowing anything else, about your situation. Hi to Lisa and Tiffany and Shine and Mrs. Pittman and Ariel and Ryan and Monkey Mo. Let's see, and I can't quite read that name there, but should I get another saline sonogram before my FET in October? I had a hysteroscopy, polypectomy, and a salpingectomy and a laparoscopic surgery in May, and was wondering if I should get my testing done again before an embryo transfer. My feeling there is that I think that you should have your cavity evaluated once a year. And in your case, and that says Blaxican B3 Beauty, I believe that says. We can, so if you had your cavity evaluated in May when you had all that surgery, then I think you're fine. No, I don't think that you need to have another saline sonogram before doing an embryo transfer. I think you're okay there. Hi to T. Andres and Wanda Witches. I think this is what that says. Wanda Witches. Coming back over here to the Instagram, the CNY Instagram side. Looks like Tiff Woodward says, I have a question. What would be the reason for my AMH to increase? It was 9 last year and 11.3 recently after I lost IUI triplets. Well, I am so sad to hear that you lost triplets there, that you lost any pregnancy at all, but especially after having been through that process of IVF. Tiff, our thoughts and prayers are with you there. So the question is there really a difference between an AMH of 9 and an AMH of 11? There can be some variability in those numbers. And the variability is because, well, things can change. It's not a number that's supposed to change based on where you are in your cycle or anything that's hormonal. But in reality, if the AMH was 11 or if it was 9, what that tells me is that either way, you're packed with eggs. And that your ovaries are going to respond as though you have polycystic ovaries. Now, you may not have polycystic ovarian syndrome, but it tells me that the ovaries are going to pay very close attention to your medication, and you're probably going to make an awful lot of eggs. And so what does that tell me for stimulation? It tells me that, well, we want to dial down the kind of dose we're going to give you for IVF so that you don't hyper stimulate. In that scenario, the ovaries are really going to be interested in making a lot of eggs for you, but quantity is not the same as quality. And so that's why we typically will try to dial it down. Fewer eggs is actually better in that scenario, and you're less likely kind of to be sick. God bless Tiff. I am so sorry about your loss there, and that's you're a testament to kind of the risk of having multiples, and one of the reasons why we really don't like you to have multiple gestations, just because it does increase those risks. But our thoughts are certainly with you. Cutie Camp says, "Oh, look at that! The Miss Cole said, cool spectacles today, Dr. Fink. Well, here I took them off. I mean, I'll put them back on if you like them." Cutie Camp says, I was wondering if you could briefly overview embryo grading, especially what the number part means. Are some numbers better quality than others? Okay, yes. And I'm going to take these off so that I can gesticulate with them, because I feel like, and if I do like this, I feel like I look really smart. Yeah. Yeah, I understand. Oh, absolutely. Or if I do like this, wait, hold on. How about that? Well, now, I look I was going to say maybe I look professorial, but I don't know any professors that wear big green glasses. So, okay. Once again, I have derailed my train of thought. So we're talking about embryo grading. Where does the embryo grading come from? Embryo grading is the process by which an embryologist looks under the microscope and basically describes features of those embryos. Grading is done of a blastocyst. So if you have a day 3 embryo, which is also called a cleavage stage embryo, they're not technically graded. They're said to be a 1, a 2, or a 3, which is a poor, a fair, or a good. And the grade really, honestly, doesn't really matter so much. People get very caught up in grading and want grading to mean something that it really doesn't. But the purpose of the grading was to try to see, could you look at an embryo and determine whether that embryo is going to be normal, chromosomally normal, versus abnormal based on some features that they see under the microscope. And if you've ever done PGT testing on your embryos, you will know, and you can attest to the fact that the grading really doesn't matter. Once you have a euploid embryo or a chromosomally normal embryo, the grade is largely irrelevant. So what I mean by euploid being more important than the grade, you may have a highly graded embryo like a 5AA that has multiple chromosomal abnormalities, whereas you may also have a poorly graded embryo, let's say a 3CC, that is fully chromosomally normal and euploid. And that low graded embryo is going to give you a 65% probability of pregnancy, while that highly graded embryo, which is chromosomally abnormal, has a chance of pregnancy of less than 5%. So the grade really doesn't count. Can you correlate grade with whether something is going to be normal or not? And the answer is no, you can't. So it's really a beauty contest. And there are really three portions here. There is a number. The number is referring to the state of really the outside part of the embryo. By the time we get to a level 6, really, or level 5, that means that the embryo is hatching. A level 6 embryo means that it is fully hatched. What's a hatching embryo? Think about a chicken, making its way out of a shell. If it's starting to peck through the shell, okay, more probability that it's going to be alive. I think I just kicked myself out of Facebook again. I think we keep losing the picture there. Sorry about that. I think I keep kneeing something down here. It's pulling the plug. All right. So if that chicken is coming out of the egg, it's more likely to ultimately be alive. Would you not agree? So a level 6 or fully hatched embryo, is a good graded embryo. A level 4, level 3 means, the extent to which that outside part is kind of all together there. The two letters refer to the quality of what they see inside the cell or inside the embryo, which is known as the inner cell mass. The inner cell mass is the portion of the embryo that will become the baby, as opposed to the outer portion of that, which is known as the trophectoderm. And the trophectoderm is the part that will become the placenta. The first letter is referring to the inner cell mass. The second letter is referring to the trophectoderm. And it really has to do with, some of the qualities that they see of looking, and there's a variety of different features that they would describe. But basically an AA is the highest grade. So an A referring to the inner cell mass, the second A referring to the trophectoderm. An AB embryo would be one that is the highest graded inner cell mass with a little bit lower graded trophectoderm. So that's what those numbers mean. And Cutie Camp is asking, are some numbers better quality than others? Basically, a higher graded embryo will have a higher graded number component, like a 3, 4, or 5, and two letters of the alphabet that are closer to the beginning, like an AA. Does that make sense? Hopefully that tells you what you're after there. Hi to Amanda J. and only real Queen Manny. It says, do you have a location near Arizona? That would be our Colorado Springs location. So, and hi from Arizona, she says. So the way the CNY model works here is that we have a team whose job it is to help you set up the monitoring that you'll do during the stimulation portion of your cycle. They get that information back. They follow your cycle with you and help to set you up for your egg retrieval. You can go to any one of our facilities for the egg retrieval. We've got Colorado Springs, which is where I am. I happen to think it's a very nice place to come and visit. There is Syracuse, which is our home office. There's Buffalo and Albany, and there is Sarasota. Those are the places currently where we are doing procedures such as egg retrievals and embryo transfers. Now, we've got Atlanta as a monitoring center. They only do monitoring there. We've got Norfolk, Virginia, which will gradually be coming online as a facility doing full service IVF. Right now, they do monitoring, and they can do some andrology, sperm related procedures, and coming along. And Dr. Kiltz has big plans for how CNY is growing. So keep your eyes out for that. But from Arizona, Colorado is your closest. Zari B says, I transferred 3 embryos, was pregnant for 2 days, and my HCG dropped. Help me understand why this would happen. Well, so it sounds like that may be what's known as a biochemical pregnancy. And a biochemical pregnancy happens when the embryo implants and it starts to grow, but then your body realizes that there is a problem with that embryo and it stops growing. Now, there are some cases where that can also be indicative of a problem with your immune system that's trying to prevent embryos from implanting. So often, if that happens more than one time, we start thinking it may have something to do with the uterine lining. But Zari, it sounds like that may be what's known as a biochemical pregnancy. Now, the other thing that happens is that sometimes folks are on an HCG booster. And if you are getting the HCG booster, then your pregnancy test is going to be positive. And so I always warn people, the HCG booster is a useful adjunct for people doing natural or modified natural embryo transfer cycles, because it's converted in the body to make more estrogen. To make more progesterone. But if we're giving you HCG, and HCG is what we test for when we're doing a pregnancy test, what's going to happen if you're giving yourself HCG injections? Your test is going to be positive. So I warn people about that. Be emotionally prepared for it. That first beta is going to be positive. And so you just have to know the real result of your pregnancy test will be from the beta that we check 48 hours later. So I think that's probably what happened there, Zari, I would have to guess. John and Lila say, do you offer payment plans? Yes, CNY does have a number of different payment plans, and no credit check, no questions asked. CNY will do in-house financing there of your IVF, which is a really nice thing. Away with Allie. Hello. Whoopsie Daisy says, I'm only here to see what eyeglasses you're wearing. So, I think I have to keep them on. I was going to take them off again. I kind of like, I don't know. I don't know which one I like better. I'm going to leave them on for now. How about that? Thank you, Whoopsie Daisy, for noticing. Over to Facebook, Mandy Mears says, thank you for helping me develop a protocol last week. I'm supposed to do 21 days of birth control starting the Sunday after my period due to uneven growth in previous cycle and cysts. After the birth control, I start stim 3 days later. If the timing works out better for fall break, since I'm a teacher, could I start birth control earlier than Sunday? Period should come Monday or Tuesday, so waiting till Sunday would be several days away. Yes, you can. So a Sunday start is just one way of doing birth control. You can actually start your birth control even on cycle day 1. If you're doing a birth control pill for cycle regulation, and this is whether or not you're using it as contraception, or you're using it to try to regulate your cycle, or in the fertility world, you're using it to try to do controls, to prime the ovaries, or to be able to control some logistical aspect. You can absolutely start, Sunday start is just kind of one of the ways to do it. But yes, you can definitely, Mandy, start that on day 1 of your cycle, the day 1 of your period. Keisha Harden says, I am scheduled with a donor counselor on 8/23 in the Sarasota office. I'm 42, never been pregnant. What would be better, fresh or frozen eggs? I also had a gastric bypass almost 20 years ago. So, also had a failed donor egg transfer 2 years ago. So, having had the gastric bypass does not preclude you from any kind of fertility treatment. So, there is a plus. Um, the question is about donor eggs. So, when folks choose donor eggs and they talk with one of our donor coordinators, um, part of the choice you will make is using fresh donor eggs or using frozen donor eggs. So you can imagine that there are probably tens of thousands of frozen donor eggs that are hanging out waiting for someone to decide that they want them. So you can walk into a donor egg cycle tomorrow. You can get the sperm there. They can take the eggs, thaw them, fertilize them, and move straight on through the process. Really, the rate limiting step in that scenario is deciding, who the donor is, because there's a lot of frozen donor eggs that are available. A fresh donor egg cycle is where that individual who is going to produce the eggs has not yet cycled or is just getting ready to cycle. There is usually a waiting list for the fresh eggs. Because it takes a little bit of time to, this is a human being that's going through the IVF egg donor process, which is entirely the first portion of IVF, a stimulation and an egg retrieval. So getting her to the point where, she's doing a stim and then she gets a retrieval, there are a number of people who are looking to have those fresh eggs. And so there is a little bit of a delay or a wait list that's involved in using fresh eggs, as opposed to a frozen egg you can go right into right away. Is there a difference? Well, an egg freezes differently and thaws differently than does an embryo. So if you have an embryo and you freeze that embryo, we know that that embryo has about a 97% survival rate. Embryos freeze and thaw very well. An egg is just a little single cell organism. It's actually not really an organism, it's just a single cell. And that single cell does not freeze and thaw as well as an embryo does, which is a functioning little factory by the time it becomes an embryo. So if you buy frozen donor eggs, there is, let's say, usually people will buy, a package of 6. So let's say that you buy 6 donor eggs and then you thaw those donor eggs. You may not get them all. They may all survive the thaw, but you may lose a couple of them to the thaw. Whereas if you are purchasing fresh eggs and you purchase 6, you're going to get 6 because they're fresh. They have not been thawed at all. Now, they still may not all fertilize, but technically speaking, if you're getting a fresh egg, you are likely, and you're purchasing 6, you will get 100% of those eggs, even though what happens with those eggs when you go to fertilize them is always going to be a question. But if you're thawing eggs, you may lose some in the thaw. And that's really the difference. And the balancing act there is, well, how quickly do you want to get into it? Because again, a frozen cycle, you can have eggs tomorrow. Really, those are here. They're waiting for you. A fresh cycle, there's a wait list for, and so it just kind of depends on how long is that wait list, and it's quite variable. Really, it depends on the donor and a lot of things about the donor. So our donor team is the best place to ask those kinds of specific questions, like how long is the wait list for a fresh egg right now? You can portal message the donor team, and they can really answer you back pretty quickly and let you know what the timing is of that. Carolyn Ibanez says, if I need to remove polyps before transfer, how long after the removal can a transfer happen? In the very next cycle, Carolyn. So we usually do the polypectomy. We remove the polyps, and a polyp is a finger-like growth of tissue that sticks up like a tree trunk or hangs down like an icicle. Um, and um, and really what they're doing is that they're taking up valuable real estate, as I like to say, where your embryo would otherwise like to implant. So we want that uterine cavity to be as normal as possible when we place your precious embryo inside. So that's the logic behind removing a polyp. But if you remove it this month, and we typically do these procedures in the first portion of the cycle, if we remove them, then you could, in theory, be doing an embryo transfer next cycle. So really should not have to wait. Chris and Brittany Whitty, I'm looking forward to my journey with Dr. Fink. Started priming today. Outstanding. Well, thank you. Honey Pogue says, hi from Fort Myers, Florida. Patient of the Sarasota office. I was diagnosed with PPROM and chorioamnionitis and had a non-viable birth at 19 weeks in July. And I'm very sorry to hear that. So, honey, so that everybody knows what that means, PPROM means premature preterm rupture of the membranes. And it sounds like this happened with an infection. That's what's known as chorioamnionitis at 19 weeks of pregnancy. That's considered a pre-viable gestational age. So viability is the point at which a baby could possibly survive on the outside. And in most cases, viability is considered to be about 24 weeks of pregnancy. So sorry to hear about that loss there. Gosh, just last month in July. I still have 3 frozen embryos and would like to do another transfer. How long should I wait to do another transfer? Gosh, that's a tough one, honey. I would say a minimum of my personal recommendation is a minimum of 3 months. Where does that number come from? There are other people who might say 6 months. Well, the chorioamnionitis, or the infection in the lining of the uterus, can lead to a chronic inflammation in the lining of the uterus that we know as chronic endometritis. I would recommend that you be tested for that, and that's done through an endometrial biopsy. And I would strongly recommend that you do that before you think about doing another embryo transfer. We'd like to know that there's not still a smoldering going on inside that uterine lining. The other thing, frankly, another real hard part to that story is I want you to be healed in here before you embark on the next journey, because we know that you can get pregnant. We want to keep you pregnant. And every day in your next pregnancy is going to be one of anxiety and worry about what's going to happen tomorrow. So I think the being healed here is an important component to you being able to really handle the stress that's associated with that next pregnancy. And you will heal both physically and emotionally, and I have every reason to believe that it will work for you, and that this will not likely happen to you again, honey. But it's a hard thing to go through for sure, and our thoughts and prayers are with you with that loss. Jeanette Santiago, for a first beta, what number is perfect? And how to know if it's a chemical pregnancy or not. Well, I'm not sure that there's a perfect number, but usually we see that number being around, anywhere between sort of 30 and 60. Is kind of what I would consider to be a normal range. You cannot tell from a single lost my picture again there. We cannot tell from a single blood test whether that's going to be a chemical pregnancy or not. Really, it's sequential betas, and what we expect to see with that beta HCG is that the number goes up, that it typically doubles in 48 hours. Liz Fisher says 6 weeks and 2 days. Oh, congratulations. Diagnosed with a large subchorionic hematoma, was taken off the Lovenox. What's the need for Lovenox during pregnancy? Well, technically speaking, in most people, there is not a need for Lovenox during pregnancy. What we use it for is really twofold. One is that it increases the blood flow that's going to the uterus and helps to prevent small clots from forming in the little tiny blood vessels that are supplying the placenta. Now, a subchorionic hematoma is literally a bruise that's underneath the placenta. Um, and they are actually pretty common in pregnancy, even without Lovenox. I would say if you've got a large subchorionic bleed, I think it makes sense to stop your blood thinner. The second reason is that there are some people who have a hereditary or genetic problem in the blood that increases the risk for that blood clotting. And that's what's known as a thrombophilia. Thrombo means clot, philia means likes to. Your body likes to form these clots. And there's a series of tests that we can do for that. And we typically do with folks who have had recurrent pregnancy loss. But really, it's, we're treating the whole population knowing that it may help some small group of the population. But at the very least, it just keeps the blood flowing there to the uterus, helps to prevent little clots. In your case, I would, Liz, stand by that decision to stop it. I think you did the right thing there. Shannon Sachs says, I am 46. Once the past 3 years had an IUI miscarriage at 8 weeks and several transfers with nothing sticking. Is donor egg the way to go? Well, at 46, Shannon, the odds of being able to get pregnant through an assisted reproductive technology like IUI or IVF, the odds are extremely low. Really, I would say it's a small fraction of less than 1%. Now, if you do something like IVF, for instance, and you make a chromosomally normal embryo, well, then your odds of getting pregnant with that embryo are 65% with that chromosomally normal embryo. But without knowing that it's a chromosomally normal embryo, unfortunately, your odds of pregnancy are going to be really no higher using an assisted reproductive technology than they would be with home intercourse, which would be a very small number, less than 1%. Like a tiny fraction. So now that said, if you're going to use a donor egg, the donor eggs in all probability will, they come from very young donors who have stable normal DNA in those eggs. And so I would say that, using your own egg gives you a very, very, very difficult uphill climb. Whereas using a donor egg to create an embryo, I think you could probably be pregnant within a month or two. It would be really a smooth sailing kind of process. But yeah, unfortunately, Shannon, at 46, it does become a very difficult process. And that's due to the DNA that's in the eggs. Remember this, the sperm that comes in, it's kind of not fair. The sperm that comes out today was manufactured in the male body about 3 months ago, whereas the eggs in the ovary have been there since before you were born. You were born with all the eggs that you'll ever have. So the DNA in those eggs over time starts to become less stable, and that's what results in that sort of situation there. Ariel asks, how long after laparoscopic surgery should I do an egg retrieval? Is a few months okay? Yes, I think so. Hello, Legit Brit. Can you speak to doing another transfer while breastfeeding? How long should breastfeeding be completed before a new transfer? Well, so we do not recommend doing embryo transfers during breastfeeding for several reasons. One is that, well, as you're breastfeeding and your prolactin hormone levels are elevated, that can interfere with the way the hormones are talking and allowing your brain to communicate with the ovaries and the uterus. As such, it increases the risk for implantation failure as well as for miscarriage. If you do have a pregnancy that sticks, it can create an environment where that pregnancy is being challenged for resources because the pregnancy is trying to take resources, whereas the breastfeeding is trying to take resources, nutritional, hormonal, and so forth. It's recommended that you have stopped breastfeeding for really, in that month. Now, a lot of times you will, continue to make milk for several months afterwards, and that's okay as long as that milk supply isn't continually being replenished because the baby is feeding. Hi to AG Beanie and Honey Girl. Christina, Honey Girl says, I downregulated for 60 days before transfer, but I had a miscarriage just before 8 weeks. Should I downregulate again before another transfer? No, I wouldn't think so. So, what she's suggesting is that she took medication for endometriosis, down regulated, sort of turning things down, turning down the volume knob on endometriosis, was able to get pregnant, but unfortunately miscarried there. That down regulation probably has an effect that should last you for 6 to 9 months, which, God willing, is plenty of time for you to get pregnant and stay pregnant. Let's plan on that one. I'm going to put that in your chart. Plan for you, get pregnant, and stay pregnant. I think you might agree. Wanda says, I was going to start, but I had to have a fibroid removed last time. They had to induce a bleed before I stopped with the fibroid since my lining was a 7. Do they need to induce a bleed again? Well, one, I'm not sure what they were going to start, whether that was going to be for an embryo transfer or if that was for a retrieval. Usually, if it's going to be for an embryo transfer, we like you to be at a kind of a baseline state. We like your lining to be thin so that you can grow a whole, fresh new lining for your embryo. If it is for a retrieval, a lot of times what happens is that your body is hanging out at a point where it thinks that you're actually at the beginning of a cycle. So you may not need to in that scenario. By the way, we got about 12 minutes before top of the hour. You are watching Fertility with Fink and Friends. I am Fink. You are friends. We almost had a very special guest in the studio this evening. Dr. Kiltz is coming to Colorado for a visit, and I had hoped that he would land in time here so that we could have had him on the program. But I think his travels got a little bit delayed, as they are wont to happen these days. By the way, if you're traveling for care to CNY, I had a friend patient ask this morning, should I, can I? There's a flight that gets in, in the morning. Can I have my egg retrieval on the same day that I am arriving? Well, theoretically you can, but gosh, so many times have I seen people having flights get canceled, having flights get delayed, and then ending up not able to do an egg retrieval despite having spent all that money on the medication and the monitoring and everything else because the airlines didn't cooperate. And I imagine there are a bunch of you out there who could share stories about that very thing. So I would say, get there the day before and you'll be much happier. It'll be much less stressful of an affair. Let's see. Sarah Beth just moved to Colorado. Welcome. Rosa says, do you recommend myo-inositol before an egg retrieval? If so, what brand? So myo-inositol is a supplement that is used for folks with diminished ovarian reserve. So Rosa, I think it depends on what your AMH is. It is particularly helpful in those with an AMH of less than 1 or greater than 3. We can also use the metformin medication, which sometimes is a little bit more reliable. There is no particular brand of myo-inositol that I necessarily recommend. Let's see. Arizona is in the building. Love that. Okay. Should I remove a fibroid that's 1.7 centimeters before IVF? If that fibroid is inside the uterine cavity, then yes, you do want to remove it, because we don't want a fibroid, which is called a submucosal fibroid. We don't want a fibroid inside the cavity if you're going to be putting an embryo there, because again, we want that environment to be as pristine as possible. Uh, so now, if that's what's known as an intramural fibroid, that's a fibroid that's just somewhere in the wall of the uterus. No, there is no reason to believe that you need to remove a small fibroid like that. It should be of no consequence at that size. Okay, let's see. Usually, when do we start meds for transfer? This comes from Jenny. Um, Typically at the beginning of your cycle. So you notify us really on cycle day one, and whether we're doing a natural, modified natural, or a medicated cycle, that's kind of when the whole process begins at the beginning of your menstrual cycle. Uh, where is the, I think it's asking where's the CLO, where's the Colorado location? We're in Colorado Springs. Oh, where's the nearest CNY to Arizona? Yep, we covered that one. Monkey Mo asks, I was wondering if we have had multiple failed transfers, 2 chemicals and 2 miscarriages, not most not making it to 11 weeks. Do you recommend doing another retrieval or use frozen embryos? Well, in that scenario, so the first thing that comes to mind there, I would want to know. I think, in your situation, you're going to be better off knowing that you have euploid embryos. The most common reason that a pregnancy either doesn't implant or miscarries is because of a chromosomal issue with that embryo. So if we can rule out the chromosome problem by and large by making chromosomally normal embryos, then you're going to be way ahead with that. There are also some specific things about your immune system, given that history, I would want to take a look at, and some different blood tests and things. So I think that's definitely worth a consultation there. But Prograf or tacrolimus is one medication that can definitely help you in that scenario. But again, I think definitely worth a talk to see what else is going on there. Should I worry about the effect of Orilissa on bones and gut health if I'm on it for 2 months? No, that's pretty short. So Orilissa as a suppressive medication for endometriosis can be taken, really for up to 2 years. If you're on it for 2 years or over a year, then yeah, that's something that you want to kind of pay attention to. Not so much the gut, but the bones. And that's the reason, in fact, there is a time limit on the amount of Orilissa or Lupron or any of those other medications that suppress that we would want. But at 2 months, no, I would not consider that to be any significant risk for you. Do you recommend multiple ERAs after a successful transfer or birth? So an ERA is an endometrial receptivity assay, and nowadays we really don't recommend them at all. They have been debunked as something that is useful. So they looked at tons of pregnancies, like thousands and thousands of embryo transfers, and ultimately what they found is that people who had an ERA, an endometrial receptivity assay to determine the precise timing of their implantation, had no better or different outcomes from people who didn't have the test. It's an expensive test. Yeah, it gives you a number, but at the end of the day, it probably really doesn't make a difference. So if you had an ERA at some point in the past, I think you're fine to stick with that number. I do not think that you need to redo that test. K Dreams, what do you think about women 43 and older doing egg retrieval sooner than normal, like around 17 or 18 millimeters in size? Yeah, so I do think that's basically you're asking at what point is a follicle said to be mature? We found after investigating, after doing, and it's classically said that in older women, women in their 40s, that it may be better to do an egg retrieval a little bit sooner, like when they're maybe around 16 millimeters. Ultimately, when we looked at thousands of of egg retrievals done in Colorado Springs and looked at the pregnancy outcomes from those, we found that really the ideal time to trigger is with a number of 18 millimeters. So there is some classic wisdom there, Kate Dreams, that says a little bit earlier in women in their 40s, but I would say really 16 to 18 is kind of the number that I'm looking for. Let's see. Liz says, when are the antihistamines stopped? If you're doing the antihistamine protocol, the Claritin, the Benadryl, the Pepcid, when do we stop that? I would stop that with your positive pregnancy test. Now, as far as prednisone, if you're on prednisone, that is not something that you want to just stop outright. We really need to taper you from that, and we do that a little bit later on in the first trimester. Annie AQ says, short cervix due to leaps. A leap procedure, can I have IVF? Is the transfer possible for those? So a leap procedure is an excisional procedure where we remove a portion of the cervix that's known as the transition zone. And that's done in the case of high-grade cervical dysplasia, which means a precancer of the cervix. When we find, and these things are screened for with your pap smear. So if you have an abnormal pap, we usually do a colposcopy. And a colposcopy is where we look with a pair of binoculars at your cervix. That's the diagnostic test to tell us whether the cervix is normal. And if we see an area that's abnormal, we can sample that tissue. It comes back to us with one of really 4 different results. It's either normal, level 1, level 2, or level 3, which goes along with mild, moderate, or severe. And the term that we use for that is dysplasia, which means precancer. If it's a level 1 dysplasia, a mild dysplasia, guess what we get to do to you? Nothing, because those just go away on their own. You leave those alone. It used to be that we would do what was called a cryotherapy. We'd do this freezing treatment on those, but we found that actually that's really just damaging people's cervixes, and for no reason, because most of those level 1s really just disappear on their own, really almost all of them. The point of that whole exercise is to see who has a level 2 or a level 3, because that's the trigger to treat it. So we want to remove those cells, remove that abnormal area, so that that precancer does not continue to progress. Cervical cancer, really honestly, is a preventable disease. And so that's the whole point of doing the pap smear. Nobody likes to have a pap smear, but gosh, it's better than the alternative. So if you have an excisional procedure such as a LEAP, can you still do IVF? And the answer is yes, Annie, you absolutely can. Now, some people have a difficult cervix to get in, but we are in the business of getting in people's cervixes. So I've never really met a cervix that we weren't ultimately able to make that magic happen. So, yep, I think you can. Is IVF the only way to get pregnant if one fallopian tube is removed and the other is blocked? So if you have no fallopian tubes, maybe they were both removed, or one is blocked and the other is gone, or both are blocked or both are removed. If there's no tubes involved, then yep, IVF is the way that you will get pregnant. Now, if you say possibly blocked, there is a possibility that when it was tested, it was just spasming and you couldn't actually just get into it. So if one tube is open, your fertility is really about the same as it would be if having one tube is essentially the same as having 2. So that's not a bad problem to have. However, this is going out to when if one's blocked and the other is missing, then yep, IVF is the choice. Do you recommend removing a dermoid before an embryo transfer? Nervous to have that surgery, but my dermoid is about the size of a small orange. No kids, but we've just been following it and watching it. So when a dermoid is called a mature cystic teratoma, it's a benign growth inside the ovary. They actually have hair and teeth in them. They can be really kind of scary looking. When things get to be about 5 centimeters in size, we start thinking, maybe they should come out, because then you run the risk of them twisting on themselves, and that's called a torsion. And if an ovary torses, if it twists on themselves, that becomes a surgical emergency. That means its blood supply is getting cut off, and be sort of the same thing as wrapping a tight rubber band around your finger and leaving it like that for a couple of days. That's probably not a good idea. So 5 centimeters, or close to five, is usually the point, cutie, that we kind of think about having surgery on these things. Just because you have a dermoid there, it is the most common type of benign growth in the ovary. So just because it's there doesn't mean surgery. Doesn't mean you need to have surgery. You can just watch it. But at about 5 centimeters, we start thinking maybe that's time for it to come out. Let's see. Yeah, let's see if I can get the last question here. Giovanna, can't make up my mind about PGT. 30 years old, no previous pregnancies or miscarriages. I would use the PGT if you get a whole bunch of embryos to help separate out the group that's more likely to get you pregnant, because it just means fewer unsuccessful transfers. If, however, you end up with 1 or 2 embryos, don't do PGT testing on 1 or 2 embryos, because you could put those embryos inside you and they're either going to stick because they're normal, or they're not because they're not. So that's kind of my feeling about PGT. Hey, we've been here for the whole hour. It's about time for us to wrap up. We'll be back next Tuesday for Fertility with Fink and Friends. I am so appreciative of every one of you joining us, throwing in your questions, and really sharing your goodwill, your love, and your care for all those people going through this process. If I can answer questions for you, you're welcome to send them to me through Instagram, and that's Randy Fink MD, and I will try to. It's hard for me to answer those during the week, but I will try to put them on my list and get them to the top of the list for next time's Fertility with Fink and Friends. So until then, every single day, the world needs more kindness. Please, one step forward with kindness everywhere you go. Remember that we are all just humans, and life is a very challenging place to be sometime. Next step forward with love. Please share that with everyone you can. And lastly, with hope, because tonight the sun goes down and tomorrow a new sunrise comes up. Tomorrow's a new day, and yesterday is just a memory. Hope for tomorrow, knowing that this whole business is not the story of your life. It is just one chapter. And what are we here to do? We are here to rewrite it together. So until next week, Dr. Randy Fink from Colorado Springs, thanks for being here. Good night.